Dr. Joyce for his 5 minutes of questioning.
Thank you, Mr. Chairman. According to CMS data from 2024 on total healthcare expenditures, spending reached a new high of over $5 trillion. Notably in this report, hospital costs, which now make up over 30% of that $5 trillion, are the steepest rising costs being paid by the American patient. One of the reasons driving this has been the trend of hospital consolidation, leading to regional monopolies dominating markets. I hope that this is a topic that this committee will explore in future hearings. For our insurers on the panel, please raise your hand if you agree with the following statement. Highly consolidated provider markets make it harder to contract at competitive rates for the services on behalf of your customers. I see that Mr. Helmsley, Mr. Joyner, Ms. Bodeau, Mr. Cordani, and Mr. Markovich have all raised their hands. Thank you. Since the passage of the ACA, we have seen costs across all markets continue to increase. One of the key issues driving this is the medical loss ratio, or the MLR, that requires plans to spend either 80 or 85% of your premium dollars on healthcare expenses. The MLR created multiple perverse incentives for insurance companies to dramatically consolidate both vertically and horizontally. The companies that you lead today are not just involved in insurance. You own PBMs, you own specialty pharmacies, you own retail pharmacies, you own GPOs, you own physician groups and practices. In some cases, you own hospitals, and you own drug manufacturing companies, and at least one of you owns a bank. This has led to alleged cases of self-dealing as your companies work to circumvent the MLM requirements. I would like to add for the record a Stat News article from November of last year entitled, United Health pays Optum physicians 17% more than outside providers. Under MLL rules, it is now in the insurer's interest to purchase as many health services that count towards that 80 or 85% medical spend requirement to ensure that Americans' premium dollars merely are just changing hands within your company's corporate structure. Since provider profits are not capped under the MLR in the same way that plan profits are, there is absolutely no incentive to keep prices low. In fact, it's in your interest to keep driving them even higher, resulting in bigger payments that can make your own corporate-owned providers and bigger profits that you can retain, legally skirting the MLR requirements. As a doctor, of which there are many of us on this committee, we took the Hippocratic Oath, an oath that says, above all, do no harm, but it is painfully evident that promise that we took is not reflected in the blatant gaming of the MLR because you are clearly putting corporate profits ahead of patients. And ultimately, each and every one of you are hurting those patients. Transparency in this area is critical for us to truly understand what's driving cost increases. And I would ask that by the end of February, in writing, to please provide to this committee the names, the size of the business areas of each subsidiary that your company owned that you have spent premium dollars that would qualify as a medical or quality improvement expense under the MLR. Can you please also provide the percentage of your dollar spend in each individual or commercial or Medicare Advantage market that went to the subsidiaries that you own? And can you provide a breakout of how your negotiated rates compare for services delivered by your affiliates versus a non-affiliate provider? Please raise your hand to indicate that you will provide the committee with that information by end February. Seeing that all of the insurers, Mr. Helmsley, Mr. Joyner, Ms. Bodeau, Mr. Cordani, and Mr. Markovich have all raised their hands. In addition, the growing physician employment that each of you operate, that is one problem. But you also own some of the largest pharmacies in our country. And this has led to a crisis among smaller and rural pharmacies, especially in my district in South Central and Southwestern Pennsylvania, closing and leaving entire communities unserved. I would also like you to provide in writing a comparison of total cost and spend for routine dispensing fees when you pay a community pharmacy in your network against what you pay a pharmacy that you own. Please raise your hand to indicate that you will provide this committee that information by the end of February.
Congressman, we don't own
I see all health
pharmacies.
insurers have raised their hands. I will follow up with questions for the record detailing these requests, and I ask that you stand by that commitment that you just made to answer these questions for my patients and for my constituents. Thank you, Mr. Chairman, and I yield back.